So Martha provided a little bit of an introduction, but the Advisory Board Company, real quick, we are a best practices solutions firm within the healthcare industry. As she said, been in the space over 35 years. Historically, folks think of us as working with hospitals and health systems, but much like the rest of the healthcare industry, in the last 10 years, the Advisory Board has become much less hospital-centric. And so you can see now, in addition to our hospital members, our post-acute and long-term care providers, we're working with independent physician groups. A lot of the physician groups that are participating in the ACO pilot are our members. Also working with health plans, payers increasingly, and even out into the product and vendor space. And so what our job then becomes at the end of the day is to sit at the intersection of all these different constituencies and to understand the market realities and then to provide unbiased guidance out to each of those sectors in turn. We are based in Washington, D.C., but we don't engage in any kind of lobbying or advocacy work, so we really are trying to be an unbiased source of information in the marketplace. As Martha mentioned, my team focused specifically on the post-acute side of the house, and so where do we spend our time? So at the most basic, we help our members navigate the future of post-acute care, and I think you'll see plenty of that coming through in today's presentation. We do this really by taking a two-pronged approach. On the one hand, we think about post-acute care holistically. So how can all these different pieces fit together to create this seamless post-discharge network that is really what referrers and payers are looking for at this point in time. But the second piece in the top right, reality is we all still do live under our Medicare regulations and have our sector-specific designations. And so you can't tell a home health agency should not be pursuing the same strategies as an inpatient rehab facility, as a skilled nursing facility, as a senior living provider. And so you need to recognize the difference between the different post-acute sectors. And so our team spends a lot of time thinking about how those individual sectors should respond within that more holistic care approach to post-acute care. Ultimately, we're doing this to really help our members become that partner of choice, as you see on the bottom half of the slide, to build those long-term relationships, secure places in preferred provider networks, and really secure that consistent referral stream. And I think what, at least for me, and I imagine for many of you all in the room, is a incredibly positive turn is that we've really seen that the way you drive these referral relationships in the business development portion of your business is through the bottom right hand, and that's the meaningful clinical capabilities. Being able to do the right thing clinically, provide the right set of services for a patient, that's really what differentiates your organization in the market these days, and will do so increasingly as we move forward. So I think you'll see a lot of these themes coming out today as we talk about episodic payments and the idea of quarterbacking the post-acute episode. So be using a couple of terms here today, largely interchangeably: episodic payments and bundled payments. So episodic payments are a lump sum which reimburses a healthcare provider for services delivered within a given time period and scope of treatment. So you can provide an episodic payment for a hip or a knee replacement, with that episode lasting, depending on the designations from the payer, 30, 60, 90 days, and the provider, who is the convener, so to speak, for that episode, that individual is on the hook for the totality of that episode, both in terms of quality of care and cost and efficiency across that episode. So that's real, at a real high level, the concept that we're going to be exploring here this morning, and the reason that we're doing so will become obvious as we go through here through our first section. So bundle payments, again, we'll be using episodic payments, bundle payments relatively interchangeably. Bundle payments really, it's this idea that instead of paying each individual provider, so paying the hospital, paying the physician, paying the post-acute provider, instead of paying each of those individuals separately and distinctly, we provide one lump sum payment for that episode of care as that patient goes across all those sites of care, and that in turn aligns financial incentives across provider types and provides an incentive to improve care coordination, to reduce duplicative tests, to avoid unnecessary readmissions and things of that nature. That is the simplistic view of bundled payments. As we will talk here over the next couple slides, that isn't practically how bundled payments really work in the country right now, but that is the concept behind them, and I'll explain why we don't just use that straightforward concept currently. You can get a sense that there's more than one way to do this from the right side of the slide. So the best known example of episodic payments, bundled payments right now, is the bundled payment for Care Improvement Initiative underway with CMS. And you can see that there are actually 4 models there, with the vast majority of organizations participating in models 2 and 3. Right now, this is the largest voluntary payment program of CMS, with over 2,000 participants, and over 1,000 of those are actually skilled nursing facilities. The reason for that is the way that we are looking at episodes within the BPCI model. So here you get a sense of how they have broken up that episode of care. So as I said, the idea of episodic payments is across an episode of care, but there are a number of different ways to define that episode of care. Here, for BPCI, we'll focus on models 2 and 3 because, as we saw on our previous slide, that's really where all of the interest is. So model 2 is the full episode of care, so all the way prior to hospital admission out through post-acute stay and including any related readmissions. And there is flexibility under the BPCI program for providers to determine the length of that episode themselves. So those post-acute services and related readmissions might run for 30 days, they might run for 60, they might run for 90. Again, this is a voluntary program from CMS, so CMS giving folks some wiggle room in terms of how they want to define that episode. Model 3, obviously holding a lot of interest for post-acute providers as it looks specifically at the post-discharge episode. So only post-acute costs and related readmissions from that hospital spend. So a couple of things to note here. One, as I mentioned, we don't actually pay under this system the way that we do here on the conceptual description of bundled payments. You do pay that way under Model 4, actually, but under Model 2 and Model 3, what happens is providers receive payment as normal, and then the convening provider is benchmarked against an episode of spend, and then either receives a bonus if they come in under that spend benchmark while meeting quality barriers, or they have to pay an additional penalty if they come in over that episode of spend, or obviously if they're right around that benchmark, no penalty. So if you are partnering with a hospital who is participating in Model 2, as the post-acute provider, your payments will continue as normal. You won't see any change to the way that you're reimbursed. You'll be reimbursed under traditional fee-for-service, but that hospital that you're partnering with, they will be paying attention to total episodic spend, and so they will be very concerned about things like skilled nursing facility length of stay, which obviously impacts the total spend for that patient, and related readmissions. They'll also be looking for ways to put patients in lower cost, clinically appropriate settings, skipping the skilled nursing facility, getting that patient directly to home. That makes our last point that I want to make here on this slide, and that is that because of this world that we see here in BPCI, there are really 2 implications for post-acute providers. On the one hand, in, for instance, Model 2, you need to be a good partner to your hospital who is now on the hook for that episodic performance, both in terms of quality and spend. On the other hand, if you're moving forward with Model 3, you need to be able to actually manage that episode directly yourself, and you need to be able to partner with your upstream referrers to successfully transition the patient to your setting, you need to be able to redesign your care to improve efficiency, and you need to ensure downstream transitions. So depending on how exactly you're getting involved in bundle payments, your priorities change slightly. Any questions on kind of the different models or mechanisms at play under BPCI? It's a little bit difficult to understand. I just want to make sure we're all on the same page in terms of a starting point. Perfect. And if you know me, you know that if I ask if there are any questions and nobody has any, I just look at that as a pat on the back, that I have literally provided you with all the information that you could have wanted, so there are no questions left to be asked. One other element to talk about in terms of bundled payments for care improvement, as if it wasn't confusing enough already, there is also this role of the third-party convener. So a third-party convener is an entity that represents a healthcare provider to CMS as part of the bundle. So this individual handles the administrative back and forth with CMS. They do a lot of data analysis around opportunities to reduce variation in care, and ultimately they assume a significant amount of the risk for the total episode spend. So you can see three really high volume third-party conveners, with Remedy Partners being substantially more prominent even than the next two. So ultimately, the majority of the bundles that we're looking at here, of these 2050 bundles, the majority are convened not by providers, but by these third-party like entities. And so this recognizes, or I think this is a representation of the fact that one, particularly on the post-acute side, most organizations don't have the data analytics capability in-house to do the type of work that's necessary to participate in bundle payments. Two, I think it raises a question, which I don't have the answer to, but it raises the question of how much interest is there really from providers in terms of participating in bundle payments versus how much of this is a business development opportunity for these third-party conveners. I think an organization like Remedy has been pretty aggressive in terms of marketing, and while that percentage is the same in terms of that breakdown, 5 months ago, we had 6,000 organizations in the Bundle Payment for Care Improvement Initiative when there was a sort of test phase 1 period before you had to assume risk. So now you have to assume risk to stay in the program, so you can have a financial penalty. And we saw about 2/3 of participating providers drop out in that time. And I will tell you that I have spoken with providers who were not aware that they were in BPCI, but somehow got signed up via Remedy in the process. So there's this interesting role of these third-party conveners, and that's something that we'll come back to a lot as we think about how hospitals or payers might also manage their episodes of care. So that was bundle payment for care improvement, and we don't have a lot of results actually from BPCI so far in terms of what's been the impact financially or quality-wise, but that hasn't stopped CMS from moving forward with additional bundle payment programs. So if you've been paying attention this summer, you probably saw CMS proposed mandatory bundle payments for hospitals in 75 different markets. So this is called the Comprehensive Care for Joint Replacement model. It is a bundle payment model for lower extremity joint replacement. And unlike BPCI, again, this would be mandatory for all hospitals within 75 different markets. There are I believe 3 markets in Ohio impacted: the Cincinnati market, the Toledo market, and I think maybe the Akron-Canton market. Did I get it? All right. So there are three of those 75 are in Ohio, and that means that for all hospitals in those markets, they will have mandatory bundle payments in place for DGR. It's 469 and 470. This is proposed as of right now. CMS is set to announce the final ruling next month, but reality is it looks like we are moving to a world rather quickly where bundled payments will be a standard part of the payment process. And in this case, starting here with the hospitals on that. You can see some of the additional details up there. There's obviously a lot of nuance. Glad to help unpack that and follow up. If anybody would like my contact information on the front of the slides, just shoot me an email. But for the purposes here today, I think the points are really twofold. One, this is a very clear signifier from CMS that we are moving this direction. This is not going to be a pilot project for very long. And quite frankly, I think there's also a little bit of a sub-lesson there that we need to be prepared if CMS decides to act. This was not something that was particularly on people's radar as about to happen, and a pretty major announcement for the industry when it did come out. Second, the reality is this creates a world where these hospitals really need strong post-acute partners to help them manage that care. And you can see there will be some possibility for gain sharing with post-acute partners under the waivers of this program. There will also be waivers of the 3-day stay for SNFs, where the hospital actually has to apply for the SNF to be their preferred partner. One of the stipulations there, the skilled nursing facility must be 3 stars or higher on Nursing Home Compare. So in essence, while patient choice is maintained, CMS is, creating a network there where the hospital is really going to be able to work only with those 3-star and higher SNFs, particularly when they want to transition that patient in less than 3 days. So patient choice doesn't go away, but if the hospital wants to use that 3-day waiver, they're going to go to a 3-star or higher SNF. And so really, again, this speaks to the importance of quality and clinical capabilities for your organizations moving forward as far as business development goes. So that's, yes, sir. Yep. So BPCI trumps CCJR in all cases, and even if it is a Model 3 BPCI participant, that still trumps the CCJR.
My next question is, this is a 90-day collective contract. The other bundles, what are the lengths of time?
So under BPCI, the participants were able to select their length of time. So you see, I think the majority of them are 60 or 90 days, but you do see range across 30, 60, or 90 days. But that 90-day length here is a good point, because that is obviously means that under these bundles, these patients will almost certainly be home for a significant chunk of time before that bundle concludes for the hospital. Yeah, so I will have to admit that I am not particularly knowledgeable about the details on the telehealth reimbursement. Basically, the idea is that similar to other waivers under ACO waivers, where you might be able to have your sort of preferred home health agency and pay a case rate for a transitional care visit home that normally wouldn't be reimbursable under traditional Medicare benefit. Same thing as what's going on here for that probably a home health agency that they partner with for that telehealth monitoring at home. You can pay a case rate or a per day rate or whatever it might be for that service, which otherwise wouldn't be reimbursed. That's the idea. I don't know all the specific details though. I'm sure there is a sort of starting point. I don't know how much the detail would be, but very glad to dig into that. Marianne.
We were at AHCA and NEFL last week. They talked about the hospitals pushing back on the start date of January. Have you heard any more about that?
I have not. I think, it's not a surprise. This, like I said, came pretty out of left field for hospitals, but I would say two things, not knowing, any specific way that the political winds are blowing. I would say, one, if you look at the goals that have been set by Health and Human Services to transition, 50% of payments into alternative payment models like bundle payments or ACOs by, I think, 2018, 2019. They've got to ramp this up pretty quickly at some point. So I think they're looking at this as an opportunity to do so. And then I think the second thing, thinking big picture here, is one, hospitals have already been on the hook for readmissions here, so they should have been paying attention to post-discharge care on this, on these DRGs already. So, again, I don't know exactly what CMS is thinking, but I would say put both of those things together. I would be surprised if CMS finds much sympathy for hospitals that don't want to get started on this immediately. But I could be completely wrong. So that's the trajectory and the world for hospitals in terms of bundled payments. What about for post-acute providers? So here we have at least the legislation on this slide should be familiar to everyone. Here we have the IMPACT Act passed into law last October, I believe. So the IMPACT Act is designed to serve as a platform for really evaluating post-acute quality of care, post-acute resource use, and ultimately driving towards a updated post-acute payment model. So you can see on the left-hand side of the slide, they're really looking to create standardized data reporting across LTACs, IRFs, SNFs, and home health providers. So this is a must to achieve the goal of providing an actionable set of data to really improve patient placement, which is another goal here. But ultimately, those are near-term implications. The longer-term implications, the passage of the IMPACT Act points us towards long-term, large-scale post-acute payment reform where CMS is better able to match payments to resource utilizations. That will likely occur either in the form of bundled payments, so we'll shift to a model of bundled payments for all post-acute services, or site-neutral payments where a skilled nursing facility, an IRF, and an LTAC will all be paid the same for the same patient type rather than different just because of the designations of their facilities. So interestingly, I think a month ago, most folks would have told you that bundled payments for post-acute care would likely be the end result of the IMPACT Act. Based on MedPAC's meeting last month, they proposed a unified payment system for post-acute care that is much more along the lines of site-neutral payments. This is just the initial meeting, an initial conversation for MedPAC, but they do have to have something a little bit more formal on the table by next summer. So, it'll be interesting to see if this ultimately pushes us to a world of bundled payments or a world of site-neutral payments in the post-acute environment. But ultimately, at the end of the day, we are moving in a more efficient direction in terms of the care that we're providing. And the reality is, if post-acute providers don't willingly move in that direction, then payers and referrers are going to move you there without really your consent. So here, kind of the world of managed care that I think most folks see and experience on a regular basis. So first, avoidance of higher cost daily settings. In a lot of markets, managed care companies will simply refuse to send patients to IRFs or LTACs or even certain patient types into skilled nursing facilities, just avoiding those higher cost settings altogether. Secondly, they're demanding lower utilization, monitoring skilled nursing facility length of stay, obviously the big piece there. And then lastly, forcing rate negotiations. So simply to receive a managed care contract, needing to take a 10% rate cut just to get in as the price to play. And so ultimately, this is what a lot of folks have been describing as the commoditization of post-acute care. If we aren't able to differentiate our organization in terms of quality and efficiency, and the world is just about price, this is what the world looks like, and it's ultimately a race to the bottom. Now, you might find it a little recognize that I just shifted us over to the world of managed care when I have been talking about Medicare bundle payments and things of that nature, but the reality is we see the same thing in both environments. Managed care is also going to be pushing more towards these types of episodic payments, and you've seen plenty of commercial bundle payment programs pop up across the country. So it's CMS pushing us in this direction. It's you're referring hospitals in turn based on those incentives from CMS, and then it's our managed care companies taking their cue from that CMS payment model as well, all pushing us to this world where one of our payment types is going to be an episodic or bundled payment. Last piece that comes along with that, I mentioned this desire of hospitals, of referrers for post-acute providers to demonstrate a different type of behavior, and they'll either go there with you, or they will force that behavior on you. Here's another way that they're doing that, leveraging what we call external managers to really come in and manage your business. So in certain instances, these are those third-party conveners like Remedy Partners and Navi Health, who have their own expected length of stay models for skilled nursing facilities, and they deploy NPs, or they partner with hospitals to deploy NPs into your facility, or SNFists into your facilities, and to manage down that length of stay out of your facility. In other cases, you have these case management solutions. An organization like Right Care Assessment, who really works with hospital discharge planners to help them place patients in the most clinically appropriate, cost-effective setting. I like this story of Right Care, and I share it with you because these organizations aren't doing anything wrong. In one ways, I know I'm sort of presenting them as, the bad guy in this story because they're going to come in and manage your business. But in another way, they aren't doing anything wrong, because what they're doing is they're taking the inefficiencies out of the system, and they're starting to push post-acute providers to a world where we can't, for lack of a better term, game the Medicare system on a per-day basis. We need to have our financial stability built on quality and efficiency. And again, if you're not willing to make that shift yourself, then these are the organizations that are going to be coming into your facility and managing your business for you. So we want to spend the rest of the time today really putting you all in a position to manage your own business and to make it so that these external third parties aren't needed, and your hospital partners aren't looking for somebody to come in and tell you how to do the right thing clinically, because your organization already does that, and they understand that, and they aren't pushing you then in turn to this world of price negotiation and this commoditization model. Because the reality is, many organizations would rather the post-acute providers step up and meet this challenge. So here, share with you the story of WellPoint and CareMore. WellPoint acquired CareMore, which is a well-established care management model focused on high-risk seniors. CareMore WellPoint then has tight control over this CareMore model, and they want to deploy this high-risk senior management solution across different markets. However, they have found that it is rather resource-intensive, this vertical integration, to put that model into multiple markets, and that limitation reflected in the quote of the CEO here on the bottom left. And so in response, WellPoint has begun partnering and contracting with health systems willing to operate a CareMore-like model. So demonstrating the right behavior, these physician groups and health system-owned physician practices are now getting these contracts with WellPoint. So that's on the health system side, but it is recognition that deploying the type of model that these payers are looking for can be the one way to get yourself that contract directly. On the right-hand side, quote from Navi Health, who we've mentioned a couple times, a self-proclaimed post-acute manager who sets a 90-day care management plan for patients and then manages them across the post-acute environment, all while partnering directly with payers to assume risk for that 90-day episode. What our conversations with Navi Health have indicated is that they currently deploy their care managers in the hospital and in the skilled nursing facilities because they don't think post-acute providers will demonstrate the right type of behavior without that individual in there. But really, they're finding the same thing as WellPoint. This model is hard to scale. And so if you think about the need for boots on the ground care managers in every market, that's not really appealing to Navi Health long term. And so eventually they would like to shed this labor intensive care management model to move to a world where they manage post-acute benefits on behalf of the plan and partner with you all to quarterback that episode. Because the reality is, we know that the best solution to this problem is direct acute post-acute collaboration. An increasing body of evidence to that point, but here I'll share with you the case of Bay Area Hospital Readmissions Reduction Collaborative. This includes over 20 hospitals out in the San Francisco Bay Area and the post-acute providers in that market. So there's nothing fancy going on here. Regular meetings where they root cause the results or reasons for readmissions, and then they implement protocols to improve clinical collaboration and address those causes of readmissions. This has resulted in a 20% reduction in readmissions in the market, and if that entire market was at risk under Medicare, it would save $39 million to the system as part of that. The alternative option is what we have outlined here, or what MedPAC expressed below. The world of remedy partners, of Navi Health, of hospital health system-owned SNFists who are looking to control utilization. The question posed by MedPAC last October, I think, is a poignant one. If we are looking to improve coordination between acute and post-acute providers, is the best thing to do really interject another third party into that process? And I think, at the advisor board at least, and I imagine a lot of you, if not all of you in the room would agree, the answer to that question pretty clearly is no. And so the world that we need to get to then becomes one where we manage these post-acute episodes through direct acute, post-acute collaboration. And that's what we're going to spend the rest of our time talking about. So we bucketed the remainder of this presentation into two sections. So the first section, we're looking at replicating those external manager capabilities. So why are these external management firms appealing to hospitals, and how do you all duplicate or replicate their capabilities and kind of put yourself on even footing? And then in the second half, how do we go beyond that, recognizing that there are unique capabilities that those external third-party managers will never be able to create that are inherent to your organization as a direct provider. So that's where we want to go for the next 35, 40 minutes or so here this morning. So our first capability, without a doubt, the most ambitious. So episode mapping analytics. This is really the core of what a company like Paradigm Outcomes or Navi Health bring to the market. They have a rich database that allows them to predict long-term pathways, patient pathways, and benchmark patient progress against those pathways. So in a frank moment, this is a capability that not many, if any, post-acute providers are going to build, and quite frankly, not many should. Ultimately, all we need is to gain access to these type of capabilities. So here we show what an illustrative model, something like this would be, where a third-party firm, such as the case of Remedy Partners, who, when they're working with BPCI Model 3 participants, bringing these arrangements to the market. Here, PAC providers directly license the analytics to better control the care plan and the care pathway across that full episode of care. So there will be some opportunities here in terms of the private market to gain these episode mapping analytics, but there might also be a world in which CMS steps up to address this in a more public fashion. At the same MedPAC meeting I just referenced, board member suggesting that CMS could acquire or build such analytics. You can see this being particularly possible once the Impact Act data collection is perhaps in place and we have more robust Medicare analytics in terms of post-acute outcomes and cost efficiency. So, two things. One, this is challenging. This is probably the one area that is going to be the hardest for a post-acute provider to compete with these external managers. But two, it's not quite as difficult as it sounds in terms of building your own multi-year database. And the reality is, even without a database, you can get pretty far in terms of this conversation, because what are these databases ultimately doing for the hospital or the health system? They're providing a very strong clinical pathway on which the patient is managed and move forward in a very timely, clinically appropriate fashion. And so that's something that is much easier for us to get our heads around and to envision post-acute providers doing, right? Having very strong clinical protocols that map to that lower extremity joint replacement, DRG, those DRGs that we're going to see under the CCJR model. So here, to demonstrate a proactive collaborative approach to pathway development, pseudonamed organization Plosser Healthcare. They came to the table with hospitals with carefully drafted versions of pathways based on industry sources such as American Heart Association, American Diabetic Association, as well as their own clinician input. With their referring providers, then they've further tweaked these pathways, and they've successfully implemented robust clinical pathways for a number of specific patient populations. You can also see on the left-hand side of the slide the components of their diabetes and their heart failure programs, their different disease management programs. So these pathways have the same type of supports that the Navi Healths of the world are offering that allow the organization here, Plosser, to very effectively manage that patient across an episode and to ensure that that protocol or pathway is followed. You can see on average an extremely low readmission rate for their patients, and they say that's for heart failure, and they cite similar results for COPD and diabetes. So even if we don't get to that world of having a robust analytical database that dictates that patient pathway, we can build strong clinical pathways and effectively manage our patients across those. And that brings us to the second capability of the external care managers that you need to replicate: care management capabilities. So we're going to spend an entire afternoon on care management because it is so foundational and it is so critical to being a part of this episodic environment, as well as other payment models. But here, for the purposes of our current presentation, just want to briefly share the story of the Visiting Nurse Service of New York. So VNS-NY, they have put their nurses, social workers in charge of placing the patient in the right post-acute setting, organizing their care, and then ensuring that patient is transitioned home effectively with the right resources, including those non-medical social supports that are so critical to that tail end of the episode. So VNS-NY, nonprofit provider of various post-acute services in New York, is building upon this model to really create strong partnerships with health plan contacts. So they developed an IT care management platform that aggregates information, patient information, across disparate providers. The platform not only collects patient data, but it also sends out critical alerts about high-risk patients. For instance, if a high-risk patient is being transitioned home, the PCP receives, their PCP receives an automated alert within 72 hours of that patient's transition home, ensuring that not only is the patient aware that they need a follow-up appointment, but that PCP's office is also aware that follow-up appointment could and should occur. This platform then connects VNS-NY to the information that they need to effectively manage a patient and to connect them to other providers to help drive that patient's care. So with that technology as a support, VNS-NY has transformed their nurse liaison role into someone who simply manages referrals to someone who serves as the health plan's agent and care manager for all high-risk patients. Interestingly, VNS-NY sent these nurses to Duke University Nursing School to teach them the principles of population health and care coordination skills as part of this process. Duke, unless something has changed, the only nursing school that I'm aware of that currently has a program targeted specifically around training nurses to be population health managers to really serve this care management role. It's a pretty interesting program. And I'm not just promoting it because I went to Duke. It actually is an interesting program. VNS-NY thinks so too. With their fleet of nurses then equipped with IT and the requisite care management skills, VNS-NY secured a contract with New York payers to arrange and care manage all post-acute services on behalf of the plan's hospitalized patients. So instead of being beholden to plan behavior or the plan's external managers, VNS-NY lined up the care coordination and efficient patient placement skills that the health plan needed, and they have secured their role as the quarterback and the agent of the plan directly instead. So again, more direct provider collaboration than bringing in that third party. So that's our second capability, developing out those care management skills. Here's our last capability that we need to, where we need to replicate what those external third-party managers are doing. So network transparency and provider selection. Health systems need a post-acute network to help with their episodic payments, to help with their readmission reduction programs, to help with their value-based purchasing scores, but they don't necessarily have a strategy far beyond that. They know they need that post-acute network at this point, but don't necessarily know how to deploy it. And I can tell you that that is the truth, because my team is currently doing a lot of work on that topic on behalf of health systems to really give them the blueprint moving forward of how to more effectively build these preferred post-acute provider networks. But in the meantime, let's talk about how you might be able to provide some assistance and support health plans in their goal of developing these post-acute networks. So Vibra Healthcare here recognized that a number of health systems needed support in building their post-acute networks, and that Vibra, an operator of inpatient rehab, LTACs, stood to lose out if the system only focused their networks on skilled nursing facilities and home health, which is the common approach that health systems take. So Vibra created their virtual post-acute care continuum, or VPAC, offering. Here, Vibra will serve as the broker of care coordination between the system and newly affiliated post-acute partners. So as part of the arrangement, Vibra helps hospitals evaluate post-acute partners for affiliation, manages post-acute quality, and then develops the structures for communication across that network. Vibra either runs the VPAC as a distinct consulting engagement, or they will include it within a joint venture deal to strengthen their value as an inpatient rehab or LTAC partner. 3 hospital partners have signed on to the VPAC program in the market, and the program went live in 3 markets this year. So Vibra has found that their position as acute rehab provider actually served them well in this because there are typically fewer acute rehab organizations in a marketplace. Patients are more willing to travel for acute rehab. The hospital can often pick Vibra as an exclusive rehab, inpatient rehab partner in a way that maybe they couldn't with a skilled nursing facility where they need a larger, where a hospital needs a larger set of partners. The other benefit from the health system perspective is obviously in the inpatient rehab setting, you're seeing a lot more commercial patients, and so this allows the hospital to have a network that not only serves their Medicare population, but their commercial population as well. So the arrangement then, I mean, if it wasn't obvious, benefits Vibra with preferred provider status and ensures that their acute rehab and LTAC hospitals have a seat at the table when post-acute networks are formed. If maybe we aren't going to take on that role of post-acute convener of a network, then what else might we do to really help with this network development and selection of participants within that? So here I share with you the example of Mid-Atlantic Healthcare, multi-facility skilled nursing provider profiled here. I think we're on slide 23. Network selection and development. This is built on the idea that to effectively manage care, you need a network of top-notch providers to do so. Mid-Atlantic serves as both a participant and a convener in the BPCI demonstrations that we talked about before, partnering with a hospital on Model 2 and also owning their own bundle under Model 3. So it's given them great justification to develop a network of strong providers to strengthen their episodic management capabilities. To that end, Mid-Atlantic wanted to ensure that it had the right home health services in line to help them meet their length of stay and readmission goals. They evaluated all the home health agencies that they worked with, requesting all home health partners to present on why they should be Mid-Atlantic's preferred home health agency partner on doing their due diligence on quality, performance, and things of that nature. It's interesting to note that in this age of performance scorecarding, where we hear so much about hospitals measuring post-acute provider performance in terms of scorecards and things of that nature, Mid-Atlantic actually, at the end of the day, their most important determination or their most important criteria was comfort, and whether or not they thought the home health agency would be willing to collaborate with them on innovative performance improvement initiatives into the future. And so this is something that my team talk a lot with hospitals and health systems about, is you don't necessarily need to always pick the provider with the current highest quality, because you might find that there's somebody else out there who's more willing to go on that quote-unquote performance improvement journey with you long term. So when you're thinking about your interactions with your hospital partners, keep that in mind. It's not just about your current performance improvement, particularly on the quality side. It's also about where you're willing to go and how you're willing to help them in the future, and that can be important to those conversations. So ultimately, by narrowing the network, Mid-Atlantic was able to establish daily communication between their nurse navigators and the clinical team at the home health agency. So this is something they couldn't do when they were working with 15 home health agencies, but if they're just working with one, they can absolutely do that daily communication. Furthermore, the two organizations hold a biweekly Grand Rounds conference that reviews readmissions and conduct root cause analysis around why those readmissions occurred. Like most folks participating in BPCI, Mid-Atlantic's still gathering and analyzing the results of this approach, but their BPCI mock reconciliations were favorable, and they did move into phase 2 this summer. Ultimate big picture takeaway from this slide is external managers are famous for narrowing their post-acute networks. So take a page from their playbook. If you want to quarterback the episode, you need to do so too. Obviously, patient choice is maintained in our current world the same as it is for hospitals looking to create their preferred networks, but there are ways to collaborate and to really create preferred downstream connections with your home health partners, similar to what we've seen from Mid-Atlantic. So that takes us through the first half of our 5 capabilities here in terms of replicating those external care manager capabilities. Any questions, any comments, anybody feeling the pressures of Navi Health in their market, or care manager coming into their building and really dictating utilization patterns?
We have Navi Health on the west side of the machine. They create a scorecard when they have a certain number of cases, so there is a lot of pressure on that side of the state to see which providers are involved in Navi Health, use their tool, and they look at how many hours a day of care that we should provide, what the score they think that a resident should get in terms of care through their outcome tool that they use. So we really think on that side, that's a reason so far in our market.
Yeah, they have a large presence in Pennsylvania, but wasn't sure if that's creeped over into the Ohio market yet. But they were bought for something like $400 million this year, so the model seems to be doing just fine. Yes, sir.
Who actually hires these firms? Is it the government that's hiring them, or is it the hospital? Do they?
Sure. So Navi Health primarily works with payers. So managed care companies are who will typically partner with Navi, but there is no reason that a hospital operating bundle payments or an ACO model couldn't partner with Navi Health to build in that care management, but their business model is built more on working directly with the payers, whereas Remedy Partners is much more about being that convener for the Medicare episode. And then, as you saw with some of those, in terms of patient placement solutions, those there are some solutions that very directly target specific hospital constituencies, such as discharge planners, and sold directly in there. All right. So let's make our shift here, start to think about, now that we have done what these external managers do, how do we do what they can't do? How do we go beyond these capabilities? And so external managers, at the end of the day, they can't force providers to enhance communication, to link IT, to forge new models for post-acute care. And it's that cross-provider collaboration that will ultimately distinguish you as the agent of choice. So payers and at-risk systems have sought to pursue post-acute assets because they need to create IT linkages. This has created an opportunity for some, including Alternate Solutions, a home health company here, to forge joint ventures that really are leveraging and built around their IT capabilities. So on the left side of the slide, Alternate Solutions has partnered with their EMR company to build the capability to send electronic summary of care transfers from hospital to home health. On the right side, they're currently building the capability to conduct secure messaging and patient status reporting between the hospital and home health as well. So why is this valuable beyond the obvious clinical benefits and patient information exchange benefits? Well, hospitals have to have 10% of their summary of care documents sent electronically to post-acute providers in order to meet meaningful use criteria. So this secures Alternate Solutions as not just a partner to the case managers, but a partner to the hospital's IT division and ultimately the CFO, who's paying attention to whether they're meeting those meaningful use criteria as well. As we know, the more access points to the more hospital executives for your post-acute organization, the better. The more conversations you have, the more angles that can play. So ultimately, Alternate Solutions capitalizes on the health system's tangible need for IT system integration being meaningful use incentives to differentiate themselves as a joint venture partner. This is our fourth capability here then, integrating across service lines. So our first step in this process is that acute, post-acute IT linkage. Our second...
Are they capturing more than what the meaningful use management capture in this information exchange?
It is my understanding, yes. But I would also imagine that it is market dependent, and depending on how many post-acute providers a health system is partnering with, they might not be able to get up to 10%. But if you look at most post-acute, post-discharge breakdowns for health systems, you see roughly 40% of their post-discharge patients going to home health. So typically, if you're able, if you're a health system and you're consolidating those home health volumes largely to one provider, then you would see that occur here.
What do we do with that information if a lot of patients are getting electronic medical records on, and we never go back to the hospital? Who's looking at that? Just go to the database, and we can just...
So the hospital is building out their EMR, and they're trying to capture as much patient information as possible. Ultimately, the more that the home health provider can capture, the more that they theoretically can individualize a care plan. They can be aware of.
Talking about back to the hospital. What are they doing with all that information? They just sit there. Are they involved in managing that case from coming back to them?
Sure. So, there would be a number of different scenarios where this messaging capability from Alternate Solutions would come into play. If the hospital has a team of care managers in place for high-risk patients, then those care managers will want to see this information, want to be involved. If this patient is part of a patient-centered medical home, this is the type of information that you want going to that primary care physician's office and ultimately, being served with that team and the health coaches and things of that nature. But you do make a good point that there is a lot of information that just sits there and doesn't need to be used. And one of the things that we're actually working on, and I mentioned that work about making these preferred provider networks, one of the big problems that we're finding is physicians in this scenario here, physicians are inundated with an excess amount of information and ultimately don't, they sort of zone out on that information. And so if you are, it's this ideal world of, right, like give me all the IT connections, but once you set that up, it can be overwhelming. And so you also need to put protocols in place to really determine what is the most important information and what do we want to flag for the physician. So you raise a good point, but you can see it being used a couple of different ways depending on how the hospital or health system is set up. So again, that's our acute to post-acute transition or connections in terms of IT. So now we need to think about our second step, post-acute providers' ability to communicate among your different settings, your provider types. So here we have an IT story from Kindred. Kindred, as I imagine everyone in the room knows, national multifaceted post-acute player with a number of what they call integrated care markets, where they own the full continuum of post-acute care. So they needed to be able to ensure smooth transitions and internal exchange across all of those, all of their owned settings. So they built an internal health information exchange and an enterprise master patient index. So that internal health information exchange is really that central communication platform that all electronic medical records can go into, and then the Enterprise Master Patient Index, if you're an IT data person, that term simply means scrubbing out duplicative patient records and making sure that they all report into a single patient record, and so you're not tracking multiple people under the same name or slightly different names when they're actually the same individual here. So this allows Kindred facilities using different electronic medical records, including what they believe to be best of breed for individual settings, such as point-click care and home care home-base, to communicate with each other. And second, it reconciles the information across all of these medical records so that clinicians can access the most up-to-date information about, across all Kindred sites of care, services, regardless of where that patient is in the trajectory that you see here. So access to this information is designed to help Kindred reduce errors from misinformation and ensure that they can conduct smooth information exchange handoffs regardless of setting in their facility. So that's our second capability in terms of integrating IT or information exchange capabilities across an episode. Beyond the capability to exchange with hospitals, beyond the capability to exchange with post-acute providers, we also need to think about a way to exchange information and improve communication with community and social services. So here to make that point, share with you the example of Civic Health. So Civic Health is a technology company working to help post-acute providers exchange information with external providers. Specifically, Civic Health provides a mechanism to share an updated patient information record securely without requiring an electronic medical record, which is obviously something that these community providers do not have. So on the left, the platform allows post-acute providers to send information to one another, and they can even send a request for information to hospitals. On the right, it populates a database of all community services in the area, created in partnership with client and community partners. Care managers in the skilled nursing facility, and then, for example, they have access to a database of all the community resources that the patient might need when they get home. Then Civic Health actually create a portal through which post-acute providers and community organizations can communicate about the patient's progress. And so love this example, love this technology, because so many of the causes of hospitalization amongst elders, such as isolation, can be solved simply with access to good social services. And so Civic Health platform that really allows to do this. So tools and techniques like this, again, they allow post-acute providers to offer a set of resources that, quite frankly, that external manager isn't going to have in each and every market, if you think about how difficult it is to scale this up. So when we apply this to patients leaving the hospital, we can certainly see the benefits in terms of reducing hospitalization. Last thing here, this section that we've been talking about in terms of integration across service lines in the post-acute environment, the examples that I've been sharing, they are all IT heavy, but don't fixate on the IT elements. Rather think about how can we provide some workarounds here. And so if you think about information exchange challenges, the good one that we just raised, information overload, that's something that doesn't necessarily need to be solved via an IT platform. You can solve that through much more simple ways by having a treat and release form that goes with your patient to the ED when they present there. And on the back of that, having a list of your clinical capabilities so the ED physician can quickly turn that over, see what your clinical capabilities are, and they can understand very quickly, does this facility have the capabilities for me to send the patient back, or do they need to admit that patient into the hospital? So these stories, again, are IT-based, but again, don't fixate on that IT piece. So beyond IT integration, again, it's important to look at these handoffs a little bit more broadly. So here I share with you the example of Ponderosa Healthcare. This is a pseudonymed organization. So Ponderosa started off as a SNF provider but a few years ago they acquired a home health service line, but they'd never really been successful at integrating those two businesses. And so as Ponderosa prepared to participate in bundled payments, they became increasingly aware of the importance of downstream integration, particularly because they needed ways to get the patient out of the SNF more quickly and safely. So they launched a pilot program at 2 of their SNFs to enhance coordination, reduce skilled nursing facility length of stay. As soon as the patient is admitted to the SNF, the home health agency performs a home assessment to see where the patient's needs will be post-SNF discharge. This makes sure that there aren't any home safety barriers to discharging that patient home when they are ready. Then if a patient is discharged without home health, the agency provides a complimentary one-time check-in at home. This ensures, again, there aren't any unidentified needs that could lead to readmission, and confirm whether that patient might need home health after all. And that one-time visit, as we were talking about earlier, that's something that is available under waivers of the BPCI program. So that's how they do that from a Medicare standpoint. So for patients who are discharged to home health, the home health nurse submits a progress report back to the SNF case manager on admission. This is also shared with the PCP to close that loop. So this is really designed to accomplish 2 things. One, it allows that skilled nursing facility to discharge the patient more quickly, and second, it connects the patient with Ponderosa's home health so that lost SNF utilization in terms of revenue is captured by that home health agency. So again, here we're talking about integration, but it's not always just about IT. Sometimes you need to think about different types of connections that you might have with your downstream providers. So this brings us into our 5th and final capability. You need to do more than just communicate with those downstream partners, you also need to think about how to support them, where you have the opportunity to equip downstream providers with additional clinical expertise to help reduce total episodic expense. So one organization establishing such care redesign, Reliant Senior Care. Reliant is a multi-regional SNF provider that wanted a way to discharge their patients sooner, but they found that partner home health agencies were restricted under fee-for-service payments from delivering the level of home care, home services that they needed, that Reliant needed to transfer that patient home more quickly. So Reliant developed their own home visits program to provide additional downstream support to its partner home health agencies to be offered concurrently with the traditional Medicare benefit. The program provides a few critical benefits under a bundle. It ensures immediate care following discharge from a Reliant SNF, removes shortfalls in service timeliness. Moreover, it allows Reliant to support patients who have been discharged more quickly and still have a higher level of clinical and rehabilitative care than is generally available under that home health benefit. So this is something developed under a BPCI program, but now Reliant actually having conversations with managed care organizations about also rolling that model out to that population as well. So this is a skilled nursing facility providing benefits to their downstream partners. You can also take a look at this the other way and receive some support from your upstream partners. In particular, we're seeing a lot of LTAC and SNF partnerships as SNFs take on vent patients that are traditionally cared for in LTACs. So this is relatively close by. Advanced Specialty Hospital of Toledo has created an EMR module that incorporates an assessment to alert SNFs when prior LTAC patients might be experiencing adverse events. For example, as the nurse enters a vent patient's routine, the EMR's alert allows the nurse to identify potential problems and then to contact the patient's physician before that escalates and turns into an emergency. So the LTAC specialty in managing ventilator patients, this type of knowledge sharing has allowed skilled nursing facilities in the market to safely manage patients following LTAC discharges. And if you're following the LTAC environment in terms of what's going on with them, in terms of bifurcated payments, you know that they now have an opportunity under these site-neutral payments to serve as a stabilization unit and to more quickly discharge patients downstream than they historically have had under that 25-day length of stay, which is also driving a lot of this. So the LTAC nurse liaison also, just to round this story out, also completes the connection back to the community PCP with a post-discharge report and providing education services to that PCP office on topics such as wound management as needed. And so this is the type of cross-setting collaboration that I think really comes to mind when a lot of hospitals talk about the idea of a one-stop shop in terms of post-acute care, that is. So these examples of upskilling downstream settings have all been clinical competence related. How do you solve problems in a bundle that a healthcare provider can't address? What about that patient at the tail risk of their episode who frequently calls 911 for non-emergent reasons? Managing a bundle also requires reducing the risk in that tail when, again, likely services have ended or patient behavior becomes unpredictable. So MedStar, this is an ambulance company in Texas, not the health system in Washington, D.C., they have found that frequent or non-emergent 911 callers were contributing very heavily to ambulances and ambulance use and subsequently ED costs. So MedStar began to develop mobile community healthcare programs not involving ambulances to reduce these patients' ambulance and ED utilization. One example, 911 nurse triage programs. Patients calling 911 with low acuity problems are redirected to an RN who works with them to find more appropriate resources. Since 2012, almost 2,000 patients have been referred to the program, and 40% have had a response other than an ambulance to the ED. Another example, an EMS loyalty program for patients calling 911 at least 15 times in the last 90 days. Here, mobile health paramedics conduct regular home visits, educate patients and caregivers on self-management, and connect the patients to resources such as their PCP. Even stronger results there, tremendous reduction in yearly ED visits among just 95 patients, an average of 17.4 visits per patient, and a 74% reduction in 30-day rehospitalization rates for CHF patients in a program specifically targeting that population. Ultimately, this may seem like competition, particularly if you have a home health agency, but it's actually a great partnership to have up your sleeve under any bundle, because even patients who are still receiving some care in their home health episode might have the instinct to call 911. So to address the needs of these patients, Claris Home Care, a home health agency in Texas, is contracted with MedStar on the program that you see here. So first, MedStar's mobile health paramedics provide backup coverage on nights and weekends for the agency, supporting needs where the agency can't send a nurse out fast enough. Second, they collaborate to redirect Claris patients who call 911. MedStar flags patients who are at risk for inappropriate 911 calls and ED utilization in their dispatch system. Then if one of those patients does call 911, MedStar goes to the scene, but they also notify Claris as well. So this way the patient gets immediate attention, and the two can collaborate and hopefully find alternatives to the ED. So no results on this story here yet, but I think given the first story, it's not hard to anticipate some positive outcomes here. So this brings us to the end, really, of our presentation. And so we've covered 5 capabilities here today, and hopefully each of those makes sense. But I'd like to pull out a few common threads to think about success under episodic payment as we close. So first and foremost, partnerships with referrers. Without a doubt, strengthening partnerships with acute care hospitals and other post-acute providers, maybe even from whom you often receive referrals. A seamless transition, complete with all necessary information about the patient's care plan and medications. This is the first step to a smooth, low-cost episode of care. Second, redesigning care within your setting. This is what we'll spend the afternoon talking about, and it's also vital to think about our role in this broader care management network. Episodic cost reduction is largely a product of reducing care variation, lowering length of stay in facility-based settings, and reducing hospital readmissions. The primary way to do that is through holistic care redesign aimed at improving quality and efficiency. Lastly, improving downstream communications. Most bundle payment programs are based on a time frame, as we talked about, 30, 60, 90 days. In particular, those 60 and 90 days are longer than a patient is likely to be in any one post-acute setting. So post-acute providers must solidify strong relationships with downstream providers, ensuring good quality and low costs even after your patient leaves your setting. And again, we'll spend a lot of time thinking about that downstream care coordination in our care management speech this afternoon. So I thank you all so much for your time and your attention here this morning. I think everyone has a well-deserved lunch break coming up. Leave you, if you are participating in BPCI directly, my team has done a lot of work in this space, so if we can be helpful, here is sort of a snapshot of some of the resources, but I'd also be glad, of course, to talk over the lunch break or any other breaks. But again, thank you all for the time this morning, and let Martha take us to lunch.
Okay. Lunch is served out here in the hall, and we will be back in this room in about a half an hour, and we'll begin our panel discussion then. Thank you.